So kidney disease, it can either be acute or chronic. And acute kidney injuries, we'll talk about that. There's a variety of, or rather there's a spectrum of kidney injury that is sort of mild and acutely impairs kidney function, and then is more severe and actually causes acute kidney failure. But chronic kidney disease will always have a very slow onset. It will have a phase, sort of a preclinical phase that's fairly long before you have any sort of observable change in or measurable change in kidney function. Okay? So with chronic kidney disease, there's some sort of underlying pathology that is slowly damaging the kidneys. Okay? Slowly damaging the nephrons, causing nephron loss, and a slow decline in kidney function. So the causes of kidney disease, these 7 things are in order of most common cause to least common cause. So number 1 and 2, diabetes and hypertension. Okay? So diabetic nephropathy, which is the diabetic kidney disease, or the kidney disease caused by diabetes, is really the number 1 complication of diabetes, long-term complication. Okay? So diabetes is the most common cause of chronic kidney disease. Number 2, glomerulonephritis, which is inflammation of the glomerular capillaries. And the inflammation can either be acute or it can be slow and chronic, okay, depending on the cause. Pyelonephritis, which is an infection of the kidney itself, the kidney parenchyma itself. Pyelonephritis is almost always ascending in nature, so it almost always comes from the urinary tract and spreads to the kidneys. Polycystic kidney disease, we talked about this in patho. This is a hereditary or genetic disorder that the main forms of it are genetic. There's an autosomal dominant and autosomal recessive, and the autosomal recessive is associated with onset at infancy, autosomal dominant onset in adulthood. And it's this condition where people have this accumulation of fluid-filled cysts that replaces the parenchyma of the kidney. Okay? And it slowly causes a decline in kidney function. Hereditary or congenital problems other than polycystic kidney disease, and then renal cancer. So by far, diabetes, hypertension, glomerulonephritis, much more common than the rest of them. So with chronic kidney disease, and we talked about this also in patho, you have some sort of slow progressive damage, or you have some acute damage that sets the ball rolling for a slow decline. So what happens is something happens to reduce healthy nephron mass, and the remaining nephrons start to hypertrophy and hyperfiltrate to compensate for the loss. Okay? And that increase in functional demand represents injury that causes inflammation and progressive loss over time. Okay. So you have some initial loss of healthy nephron mass. The remaining healthy nephrons hypertrophy and hyperfiltrate. Right? That represents an injury which causes inflammation and loss over time. Now the stages, there are 5 stages identified in chronic kidney disease, and they are really defined by the status of GFR as measured by creatinine clearance rate. Okay? So the stages are defined by the status of GFR as measured by the creatinine clearance rate. So a normal GFR is approximately 125 mils per minute. Okay? A normal GFR for an adult is 125 mils per minute. Now, excuse me. In stage 1 and stage 2, there is really barely a decrease in GFR. Okay? There's really barely a decrease in stage 1 and 2. There is certainly a decrease. It's very, very small. And it's because of this compensatory phase, right, of this early chronic kidney disease. Okay? The healthy nephrons are compensating, hyperfiltrating to maintain a near normal GFR. Now, when you start to get into stage 3 and 4, you start to see much more significant declines in GFR. Okay? Until you finally, at stage 5, you really have GFR is equal to or less than 15 mils per minute. So you went from 125 mils per minute to 15 or less mils per minute. Okay? And as you can imagine, at stage 5, there's almost no kidney function to speak of. Okay? And so now treatment is really focused on renal replacement therapies, like dialysis, like transplantation. Okay? Now, as this kidney disease progresses from stage 1 to stage 5, you will see increasing symptoms, increasing severity of symptoms, okay, and we'll talk about what those symptoms are. You'll see elevations in plasma creatinine, okay, elevations in BUN. There's a couple of terms that's used to describe that elevation in creatinine and BUN. There's azotemia, there's uremia. Okay. So there's a couple of terms that come up when you start talking about moving up in the stages of chronic kidney disease. So some of the causes. Okay, so we're going to talk about some of these disorders that cause chronic kidney disease. Nephrosclerosis. Okay, so the term sclerosis sort of is it translates as a hardening, right? So nephrosclerosis is a hardening of the renal artery, and it's most commonly caused by prolonged hypertension and diabetes. Okay? Most commonly caused by prolonged hypertension and diabetes. Now, what precedes arteriosclerosis? What precedes that? What's that? Hypertension and diabetes. And hypertension and diabetes represent an injury, right? It represents chronic endothelial injury that leads to atherosclerosis, which then leads to arteriosclerosis, right? So just connecting this to what we learned in the cardiovascular system last semester with atherosclerosis and plaque formation, okay? So nephrosclerosis is really this hardening, right, this fibrosis of the renal artery. Okay. And what happens when the renal artery undergoes this change is that you end up with a decline in renal blood flow and necrosis of tissue. Okay. So it's a major cause of chronic kidney disease and end-stage kidney failure. This is really the reason why diabetes and hypertension are the leading causes of chronic renal failure. So nephrosclerosis is described as either being benign or malignant, which, you know, the terms benign and malignant doesn't mean one's good and one's bad. Both are bad, but it's, you know, one's early and one's late, okay? Or one is less severe and more severe. So malignant, benign nephrosclerosis is the less early. Malignant nephrosclerosis is a significant, most often associated with significant hypertension, where the diastolic blood pressure is above 130. Excuse me. It can occur in young adults. It's twice as often occurs in men compared to women. And that decline in renal blood flow as a result of the hardening causes necrosis of the kidneys, slow necrosis of the kidneys, and eventual replacement of the kidney parenchyma with fibrotic tissue. Okay. So this is one route to getting to end-stage renal failure. Now, the next two syndromes, okay, they are not disorders per se, okay? They are syndromes, meaning that they are a collection of signs and symptoms that occur as a result of potentially a variety of causes, but it's sort of this phenomenon that happens often in kidney disease. Okay? So acute nephritic syndrome, so there's nephritic syndrome and then there's nephrotic syndrome. Those are the two syndromes we're going to talk about. Nephritic syndrome or nephritic syndrome and nephrotic. Nephritic, it's inflammation. Okay? It is an acute inflammation of the glomerulus, of the glomerular membranes. Okay? Otherwise known as glomerulonephritis. Nephrotic syndrome is something else. Okay? Glomerulonephritis, inflammation of the glomerulus, it can be caused by a variety of things. Okay? One of the more common causes is a type 3 hypersensitivity reaction, which was the hypersensitivity reaction where your body produced antibodies against some pathogen, and then in the aftermath, there's all this shrapnel, right, circulating, these immune complexes circulating. And when your body tries to clear that shrapnel, it gets stuck in the glomerular membranes. And it causes inflammation and damage. So very commonly, this is a great example of this is this post-streptococcal glomerulonephritis. Okay? So sudden onset of a very severe sore throat. Okay? You look down your throat, there's these little white spots on your tonsils. You got swollen lymph nodes, okay? You've got a strep infection in the back of your throat, okay? That strep bacteria, if you don't get treated by with antibiotics early with a strep infection, your body starts to produce antibodies against the strep. And then what happens is that shrapnel phase, right? So as your body clears the strep infection, you have all of these lysed bacteria, right, bits and pieces of cell wall attached to antibodies, right, those immune complexes. And they start to get deposited around your body. They deposit themselves in your skin. They deposit themselves in your joints. And they deposit themselves in the glomerular membranes. Okay? So you see rashes and hives. You have joint pain. And you have glomerulonephritis. Yes, ma'am? What's interesting is it's not an inappropriate response. That's the thing. The antibodies are against this harmful pathogen, right? It's just the tendency for, it's very pathogen specific, right? So it's the fact that these streptococcal bacteria have these really elaborate cell walls that then the antibodies get attached to. And it's really just this difficulty your body has in clearing the aftermath of an appropriate response. Yeah, that's really, the inappropriate response is really just when it gets stuck in a place, it triggers inflammation. That's the sort of inappropriate part of it. Yeah. Yes? I'm sorry, say that one more time. It's not 100%, right? It's not that anybody who isn't, that doesn't get early treatment, but I don't know what the probability is, but that's usually what the presentation history is, that it's a untreated streptococcal infection that proceeds into this, yeah, inflammation. Okay. Now, the inflammation, right? So the immune complexes get deposited in the glomerular membranes. You have this inflammation, and then the inflammation, you get, you know, this thickening of the membrane because of the edematous part of the inflammation, and it causes a decrease in GFR. Okay. And with that decrease in GFR, you get all of the symptoms that accompany that, right? So you get fluid volume overload, you get a decrease in urine production, you get an elevation in creatinine. Okay. So in the post-strep glomerulonephritis, it's an acute condition, right? It's something that's going to happen very precipitously. This is going to be an example of acute kidney injury leading to potentially intrarenal failure, okay? Intrarenal kidney failure. Okay. Now you can see nephritic syndrome caused by other forms of glomerular injury and inflammation, but the post-strep is really is a really good example of it. Excuse me. Nephrotic syndrome is different, and it is characterized by an increase in the permeability of the glomerular membrane. Okay. And As a result of that increase in permeability, you get albumin loss. Okay? So with nephrotic syndrome, something has acutely injured the glomerulus, and albumin leaks through, and you see this really significant proteinuria. Okay, this very, very significant proteinuria. So you get this marked increase in protein in the urine. You get this decrease in albumin in the blood, right, which often causes diffuse edema. Okay? And with this decrease in albumin, this is that kind of edema that we talked about before the last test, where it's this paradoxical fluid overload, right? Because the fluid leaks out of your blood vessels, it gets in your interstitial space, right? Which means that you have edema, including potentially ascites, okay? Whenever albumin levels go down, the risk for ascites goes up. And then what happens to your blood pressure? What's that? It plummets, right? It crashes. Your blood pressure goes down. That stimulates the renin-angiotensin system. Heart rate goes up. You start retaining fluid and water. So it's a paradoxical fluid overload, right? Because you have all of this fluid, it's sitting in your interstitial space, and you can't keep it in your blood vessels. Okay? So individuals with nephrotic syndrome will be highly edematous. They may even have some degree of ascites. They'll have low blood pressure, high heart rate, okay? High urine outflow, right? High urine outflow. Because as you can imagine, if you're leaking protein, right, water's going to follow that protein. Okay? So one of the biggest tasks for nephrotic syndrome is replacing this albumin. Okay? Replace the albumin. Now the liver if the liver is healthy, it is going to replace the albumin. It's just not going to be able to replace it at a rate that can keep up with the rate of loss. Okay? So replacing the albumin, or helping the body replace the albumin, and correcting the cause of the nephrotic syndrome is going to be critical. You actually see a bit of nephrotic syndrome or early nephrotic syndrome with women who are undergoing or experiencing preeclampsia. So women who are pregnant that have this disorder, preeclampsia, that's associated with actually an elevation of blood pressure, paradoxically, they will have damage to the glomerular membranes, and they will have protein in the urine, okay? And they will be edematous. Right? They'll gain a lot of water weight very, very quickly. Yeah. It's an osmotic diuresis. So if you think about the GFR, right? Remember, we had the capillary blood pressure promoting GFR, hydrostatic pressure opposing it, and oncotic pressure opposing it. Now you're losing the protein. So now there's this oncotic pressure pulling, right? Increasing GFR. So with nephrotic syndrome, you actually have an increase in GFR because of this increase in permeability and the loss of albumin. So it's an osmotic diuresis, this pulling of fluid out. Okay? And this these flow charts are from your textbook, as you probably can imagine. So damage to the glomerular capillary membrane, loss of protein, okay? Excuse me. You'll also see this parallel or this subsequent hyperlipidemia as a result of the loss of albumin. The loss of albumin actually stimulates the liver to synthesize new albumin and for some reason also lipoproteins. But the low albumin decreases oncotic pressure. You get generalized edema, but low blood pressure, activation of the renin-angiotensin system, and sodium water retention and more edema. Okay. With treatment, acute kidney failure or acute kidney injury will progress through 3 basic phases, and it's very stereotypic. The first phase is during the injury, and this is when urine output declines, the oligoric phase. BUN and creatinine levels rise. You get this hypervolemia, edema, weight gain, high blood pressure. That's followed by, with appropriate treatment and correction of the problem, you get this compensatory diuretic phase, okay? Where the person has an increased urinary output. The output can be quite high, from anywhere from 1 to 2 liters a day to 4 to 5. They have an inability to conserve water and sodium, and as they start to get rid of this nitrogenous waste that they didn't get rid of, you get this osmotic diuresis, right? And then finally, a recovery phase happens when the GFR starts to normalize, and you get a subsequent normalization of BUN and creatinine and urine output. Okay. Excuse me. Now, whether it's a result of chronic kidney or acute failure that was not end-stage renal disease or end-stage renal failure has some very typical manifestations, typical consequences. Okay? So based on, and this is a slide I pulled from Patho, based on the basic roles of or functions of the kidney, you see the consequences of a loss of those functions. Okay? So sodium and water balance, kidney is responsible for sodium and water balance. When that doesn't happen, what you end up with is this retention of sodium and water. You get this elevation of blood pressure, increased vascular volume, leading to edema, leading to potentially to heart failure as the workload on the heart is increased. Okay. Lack of potassium balance causes hyperkalemia, okay, which also puts the heart in danger of conduction problems, right, and cardiac arrest. The lack of elimination of nitrogenous waste, okay, and that's a buildup of things like urea and creatinine in the blood. This creates this syndrome of uremia, and there are multiple consequences to uremia. It increases the risk of pericarditis. The nitrogenous waste starts to deposit in the skin, and the person can have intense itchy pruritus. It affects the function of the GI system. So the person can have loss of appetite and poor nutrition. You can have neurological manifestations as it interferes with the excitability of the brain. You can have sexual dysfunction. The nitrogenous waste also interferes with coagulation. Okay? So you get these coagulopathies. With a lack of erythropoietin production, you see anemia, okay? Low red blood cell count anemia. a lack of acid-base balance causes acidosis. And when you have acidosis, what can happen is you end up pulling phosphate out of bone to buffer this acid. Okay. As you pull that phosphate out of the bone, it causes a weakening of the bone and these osteodystrophies. Now, phosphate elimination has gone down, so you're pulling the phosphate out of the bone, and you're not eliminating the phosphate because your urine production is impaired. And when phosphate levels go up, did we talk about this? What happens to calcium? It goes down because phosphate binds to calcium. So calcium is chronically low because any calcium that's there, phosphate starts to attach to it. Also contributing to the hypocalcemia is the loss of vitamin D activation that allows you to absorb calcium from your gut. When calcium levels are low, it stimulates an endocrine organ called the parathyroid gland. Okay? And this isn't really critical, that this will not show up in any place in the test. But the parathyroid gland produces parathyroid hormone that breaks down bone to try to release calcium, right, to correct for the hypocalcemia. So, but this mechanism doesn't work because this low calcium stimulates the breakdown of bone, and then the calcium that's released gets taken up by the phosphate. So this hypocalcemia never gets corrected. And so what you end up having is this constant breakdown of bone and weakening of bone. So you have this fluid volume overload, sort of key things: fluid volume overload, hyperkalemia, acidosis, hypocalcemia, hyperphosphatemia. Okay? So when you look at what is happening with dialysis, really key thing is you're trying to get rid of some fluid, you're trying to get rid of extra potassium, get rid of extra phosphate, introduce some calcium. Okay. What else? Supplement the red blood cells, right? So that often transfusions are necessary, or erythropoietin is given. Okay. Introduce bicarbonate to correct for the acidosis. All right. So these are some of the things that dialysis is doing, and including like getting rid of the nitrogenous waste. Okay. So what do we see when we assess for end-stage kidney disease? There are stereotypic things that you see, signs and symptoms by system. So neurologically, you'll see weakness and fatigue and confusion, inability to concentrate, seizures, restlessness, behavior changes. Okay? On the skin, you will see this sort of gray-bronze color to the skin, dry, flaky skin, pruritic skin, very itchy. In the cardiovascular system, you will see hypertension because of that fluid volume overload, edema, distended neck veins, okay, hyperkalemia. The pulmonary system, because of that fluid volume overload, you can hear crackles in the lungs, which suggest pulmonary edema, depressed cough reflex, a shortness of breath, tachypnea. Okay. the musculoskeletal system, muscle cramps, loss of muscle strength, which is mostly caused by the potassium, bone pain, bone fractures. The GI system, you'll have this ammonia odor to the breath because of that nitrogenous waste. They'll have this persistent metallic taste in their mouth, anorexia, nausea, vomiting because of that nitrogenous waste, constipation or diabetes. You'll see anemia and thrombocytopenia, meaning low RBCs and low platelets. Okay? And then in the reproductive system, that uremia also causes amenorrhea in women, testicular atrophy, infertility, decreased libido. Okay? So it really affects all the systems of the body. End-stage kidney disease necessitates renal replacement therapies. Okay? And renal replacement therapies include various types of dialysis, where you have this, basically this artificial process to replace the kidney function, and then kidney transplantation to literally physically replace the diseased kidney. Okay. So these different forms of dialysis, the basic mechanism for dialysis is the use of both filtration and osmosis to change the composition of blood in order to correct for this loss of renal function. So you have this dialysate, or this dialysis fluid, that has a special composition that promotes the movement of solutes out of the blood or into the blood in order to replace or eliminate solutes that are imbalanced. Okay? So, for example, people with end-stage renal disease, their fluid volume overloaded, right? So what do you think is the concentration of the dialysis? Really high, because it wants to pull fluid out of the blood. Okay? So the dialysate fluid is extremely concentrated in order to osmotically pull as much fluid out of that blood as possible. Okay? What do you think is the potassium concentration of the dialysate fluid? Very low, maybe no potassium. So it pulls the potassium out. What do you think the bicarbonate level of that dialysate fluid is? High, so to encourage the movement into the blood, right? So this is what we're talking about. We talk about dialysis is this very carefully constructed fluid to promote the correction of all of these problems in the blood. Okay? And the cellophane membrane, this is the semi-permeable membrane where the blood and the dialysate fluid interface, right? That allows for the movement. So you have a catheter attached to an artery moving blood out, going through this is hemodialysis, okay? Taking blood out, moving it through the dialysis machine where it can interface with the dialysis fluid, and then the dialyzed blood coming back into the person's body into a vein. Okay? So you're literally taking this person's blood out of their body, putting it through an artificial kidney, and bringing it back. Okay? So this is why it takes 3 to 4 hours several times a week, because it's a slow process to do this. And we've got this heparin to decrease the likelihood of clotting and to help correct for this coagulopathy that people tend to have with, excuse me, with end-stage renal failure. Yes? They have oftentimes what's called an arteriovenous fistula, which is it's something to facilitate. It's a port or a I don't really understand it very well. It's in the arm and it facilitates this movement of blood in and out. Yeah. Yeah, yeah. Yeah, exactly. Yeah, yeah. I'll admit that was part of the reading. I was like, I will catch up later. But it's very well described in your textbook. Yes. So the anemia is because it's not producing erythropoietin. Yeah, so you don't get that stimulus for red blood cell production. And then the coagulopathy, the increase in nitrogenous waste tends to cause this enhanced clotting. So you're more prone to blood clotting. There are also two methods of continuous hemodialysis. Okay. There's some slight differences between the two, but basically the advantage of these two is that first of all, it's continuous, so it's something that is always happening. It's a little device that they have that allows continuous dialysis, but it's a sort of a smaller volume at any given time that's being dialyzed. And it also, as a result, you have less of a hemodynamic change, so you're less vulnerable to like a dramatic change in your blood pressure because you're pulling out less blood at a time. Okay. But these continuous dialysis techniques are things that are it necessitates a trained critical care nurse to set up, monitor, and also discontinue. Peritoneal dialysis is really the least, it's associated with the least complications, peritoneal dialysis. Because in peritoneal dialysis, your blood is actually not leaving your body. What's happening is that dialysis fluid is being introduced into your peritoneal cavity, and the peritoneal membranes are actually acting like the semi-permeable membrane of the dialysis. So the dialysate is put into your peritoneal cavity, you get this exchange with the blood, and then the dialysate fluid is taken out. Okay. Now, and so really the only care and complication is in the rate of removal of the fluid and rate of putting in the fluid, and then care around to prevent infection at the insertion site.